So we're at Myeloma 2022 in Scottsdale, Arizona. My name's Gareth Morgan. I'm joined by three of my colleagues.
Rafael Fonseca from the Mayo Clinic in Arizona.
Leif Bergsagel from the Mayo Clinic in Arizona.
And I'm Keith Stewart from Princess Margaret Cancer Centre in Toronto.
It's been a great 2 days of science and interaction, and today we're just going to wrap up the meeting and discuss some of the highlights of this morning. So, Rafael, what was the highlight for you?
Boy, there's so much to talk about, but I have a special place in my heart for Venetoclax. And Larry Boyce did a fantastic presentation, as always, regarding the biology behind how we should think about BCL2 inhibitors, in particular the selection of patients, the prediction of those that might be more likely to respond versus not, but really a very deep understanding of the molecular mechanisms regarding the efficacy of this drug. So I hope to see a lot more like that, analogs. And also at some point, interestingly, he said, I won't talk about MCL1 because it's just been a path of frustration. So, but we couldn't hope for something like an MCL1 equivalent to what we have for Venetoclax.
So do you think we can predict sensitivity to Venetoclax in the laboratory now? I
think to a large degree. I think if you take a very pragmatic approach, I would still say 11-14. You could expand that by lymphoid morphology, maybe cyclin D1 expression, but we need to get to the point that we're more precise than that. So you need that last 15-20% of patients. Dr. Gupta had the paper on flow cytometry. I think there's some of the functional work that could be done as well too. But for our audience, if they're clinicians, just 11-14, always think that Venetoclax is an important tool.
Yeah, and it gives you options in some of the earlier stages of disease and amyloid as well.
Of course, there's nothing more rewarding than seeing a second opinion in someone who you find in the record at 11-14. I've actually used it now frontline in one patient who, not quite frontline, but the patient was given a couple of cycles for primary plasma cell leukemia, total failure of therapy, sent to us. So we actually used combinatorial strategy, but we added Venetoclax and the patient is in a stringent CR. So I hope to see more studies in that area.
What did you think about what he said about African Americans?
Well, that was very interesting. One of the things that Dr. Boyce showed was that there might be a differential ability of patients that are African Americans to respond, whether, even when they have this 11-14. It's interesting that we have seen that there's other aspects of the 11-14 that still need to be sorted out. At ASH, we saw the presentation that we know it's slightly more common in younger people, and it might be associated with that genetic predisposition to develop multiple myeloma by the familial events in about 9% of myeloma patients. So I think the story still needs to be connected a little bit better.
Great. Leif, what was the highlight for you today?
Well, the big takeaway for me was T-cell exhaustion. So the second half of the session today dealt with the therapies that look so exciting, bispecific antibodies and CAR T-cells. And they're really, I think the clue to making those therapies work better is to understand the mechanism of resistance. And we heard yesterday from Marta Casey that it looks like T-cell exhaustion in a preclinical model was an issue. And then we heard today from Paola Neri with elegant studies in patients really seeming to show that T-cell exhaustion was a major factor. And then Dr. Einzeley, in his keynote talk, really dealt in how for both CAR T-cells and bispecific antibodies in patients, T-cell exhaustion is something that we're going to need to understand better and to overcome. So Dr. Einzeley had some suggestions of one, limiting the therapies for bispecifics. So he said maybe 3 months as opposed to continuous. He also talked about checkpoint inhibitors maybe as a way of dealing with that. But I think understanding the mechanism of resistance and how best to use those therapies is the real.
So a couple of interesting things came out of that. And so I was fascinated by the spectrum of infections that occur in these patients. And I wondered what you thought about that.
Well, I had never really thought about what's the difference between CAR T-cells and bispecific antibodies. And then Dr. Einzeley sort of explained it to me really nicely. With CAR T-cells, you're exhausting all your T-cells. Whereas with bispecific antibodies, you're exhausting all your CAR T-cells. Whereas with CAR T-cells, you're just exhausting the one CAR T-cell. So if you exhaust all your CAR T-cells, it appears that you get a profound T-cell immunosuppression, which is very different than what you're seeing with CAR T-cells.
So what was the highlight for you?
Just to come back to some things we haven't talked about already, I think that the protein-degrading drugs have huge promise, and Dr. Kumar discussed those. We haven't seen any clinical results yet in myeloma, and we're anxiously awaiting those, but the preclinical data looks very impressive. I think there were some important questions addressed about how much can one push Icarus degradation as the mechanisms of action versus other maybe bystander pathways. And then again, I think to re-emphasize what Leif said, the world continues to be just transforming in front of our eyes with immunotherapies, T-cell engagers, CAR-T, and the focus now is clearly turning from they're absolutely decimate myeloma on day one, but how do you sustain that over time? And there were a lot of different strategies talked about that potentially could make the initial blast better. They could be upregulation of the target with gamma secretase inhibitors, and there could be mechanisms to overcome T-cell exhaustion by
So
giving
you've presented
breaks
some
of
stuff about targeted therapies and targeting protein-degrading kinases. So, and we heard from Robert Orlovsky about targeting RAS. So he actually came over a little negative about targeting RAS. What do you think about targeted therapy now in light of this amazing results with the immunotherapy?
Well, targeting specific kinases where there's a kinase mutation is not proven to be a very successful strategy, I think, because of clonal escape. And I always think back to, I think it was actually Larry Boise that first did the yin and yang curve. And the drugs that work in myeloma tend to target broad mechanisms of survival for plasma cells as opposed to specific targeted kinases. So proteasome inhibition, cereblon degradation. Today I mentioned another possible pathway, which is targeting the lysozyme as another sort of broadly acting plasma cell survival strategy. So my guess is for now, the very patient-specific mutation targeting isn't going to get us where we need to go to. But I think we continue to look at things that keep plasma cells generically alive, when it's NF-kappa B or whatever, that's where we'll have most success.
So I heard kind of terrific messages about understanding disease biology, targeting disease biology, targeting the immune system. And so what I'd like to get a comment from each of you is around how do you think we're going to go forward in the next couple of years to improve patient outcomes? What do you think is really going to make a difference?
I think I would say that, we've learned that combinations are the way to go, and that's going to be true for targeted therapies. I think the overlap that you have by the various mechanisms of potential escape or clonal heterogeneity could be covered in a larger fraction of patients if we do that, but also very early introduction of the best therapies is going to be critical. So the designs that we saw, for instance, from the EMN, where they're going to use bispecifics, post-transplant, we're seeing CAR T cells up front. I think lining up all those players is going to be, critical for our success. And I've always believed, I'm being quite open about this, I do think myeloma is curable, only a small fraction, but it's curable. But I think if you bring all of these players together, that fraction is going to grow.
So we have great tools. How are you going to use them, Leif?
That's exactly what I was going to say. You stole my thunder. I think maybe we're all thinking the same thing. But I guess how else might the field change? I wonder if we're maybe moving away from continuous therapy with the idea that we have all. I mean, when all you've got is melphalan or thalidomide, you use it indefinitely. But now that we've got all these different therapies and we can get such deep responses, I think you didn't mention MRD. There's something really, going for the minimal residual disease, using that as an endpoint and using all of our therapies to get there.
So we heard a great talk from Dr. Martin.
I thought Leif was almost going to say we didn't need melphalan anymore. It was going to be a historic.
And I'm going to say we don't need fish anymore. We're going to go to MRD.
Anyway, with that, I think these guys have covered it. I think we're going to.
So Tom gave a great talk. So is CAR-T the only winner? That's what he was implying, the great multi-log reduction in disease burden.
There's absolutely no doubt that CAR-T therapy is the best thing we've seen ever in our lifetimes in terms of controlling myeloma in the acute setting. I think we need longer follow-up. We need to manage toxicity better. We need to figure out to get it into more patients with the manufacturing delays. But as far as I can see right now, I'm kind of on Tom's side. There's nothing being quite as powerful as CAR-T therapy, particularly with the sort of bivalent CAR-Ts.
Okay, so thank you guys.
I think it will replace transplant if you want to.
So autologous, the days of autologous stem cell transplant are definitely limited, I believe.
Yep.
So thank you guys. It's been a great meeting. it's never a great time to be a patient, but I think there's more hope for cure at the end of this meeting after seeing these new tools that we have. And I think I'm very excited about the way forward and getting more people into deep responses and keeping people in those responses permanently. So thank you guys, and thanks for your great answers to the questions.
Thank you.
It's been another fabulous meeting, and we hope to see any of you in the audience who are interested. We'll be back in Madrid next year, 2023.
Great. Thanks so much.